Yeah, if you think at the past 10, 15 years, I mean, probably we thought that after beta blockers and ACE inhibitors, we wouldn't have had any further advances. But then we had the implementation of devices, so ICD and CRT are extremely important. So pacing and biventricular pacing and the implantable cardiovascular devices, these have made a big difference. Then we had drugs, implementation of drugs like the mineralocorticoid receptor antagonists, and they have been extremely effective in reducing further mortality, yet they still have to be fully implemented into clinical practice. So we have a powerful weapon, but still needs to be fully implemented. And more recently, we've had drugs working on the heart rate, like ivabradine, that is effective in reducing mortality and morbidity in patients with heart failure. Last year, we had the presentation of the data on LCZ696. That is very promising. What is important with these agents will be to see the real applicability to clinical practice, to see whether patients included in the trial will be reflecting the overall population of patients that we treat every day, or the treatment, at least initially, will have to be just for a selected group of patients. But of course, ivabradine and LCZ696 had made a big step forward. And we have new drugs on the horizon, and probably will take another 2 or 3 years in order to see the results. But I think we are in a nice new phase in heart failure with new drugs coming. It very much depends on the individualization of therapy, because you may have heard about the LCZ696, and it may seem that makes a big difference. But then if you look at the specifics of the population, maybe cannot be applied to all. And the same with ivabradine. Ivabradine is very effective, but still it works in patients with sinus rhythm. So what is important is more to select the patient population and apply those drugs into the correct patient populations. But for sure, ivabradine and LCZ696 are effective drugs to be implemented on top of the existing therapies. I think that there have been conflicting evidences on estrogens. There have been very good epidemiological data and small trials showing some effects in some group of patients. Then there was a big trial conducted in elderly women that are not the women that should be the target for that type of therapy, that basically ruined the market, because it showed an increased risk of events in those women who were very, very old, that usually are not prescribed hormone replacement therapy. And unfortunately, that was the end of the story, because it's unlikely that any other study will be performed after that, just because it was poorly conducted. Regarding testosterone, I think we lag 20 years behind the science of estrogen. There are data suggesting that testosterone deficiency is associated with an increased risk of cardiovascular disease, and testosterone may be effective. We have evidence that it's working in patients with heart failure and cachexia. We don't have clear evidence in ischemic heart disease, and we need a big trial or a decent trial to show efficacy once and for all.